So can I welcome everyone here today. Thank you so much for giving up some of your afternoon to join us. Although I think based on the response rate we had for this event, I think people were very excited to come and hear from the Shadow Secretary of State for Health and Care. Thank you, Wes, so much for joining us. We were so thrilled when you said you would come and have this in conversation today on a topic which is so close to reform's heart, and we're doing a massive project which hopefully everyone in the room is already aware of, called Reimagining Health, which I think touches on actually a lot of the things that you've already spoken about in terms of the need to modernise, innovate, create a long-term sustainable model for healthcare, which I hope we will get into. The way we're going to run this in conversation is I get the luxury and the privilege to start asking some of the questions, and I'm going to start with, I suppose, what has to be the most obvious part of reform, which is the short-term crisis that the health and care sector finds itself in. But I do very much want to then move on to the longer-term vision and the 10-year plan that you've mentioned, and what we need to do to actually be able to deliver both a world-class but also financially sustainable, patient-centric model for our healthcare going forward. And then I will open it up, of course, to questions. So the first half will be me asking Wes questions about those areas, and then we'll open it up to Q&A. I am conscious it's very warm in here. We were just discussing the kind of unseasonal weather. So I know some of the gentlemen in jackets, please don't feel you have to stay in jackets if it's more comfortable to take them off. We do have windows open, blinds are down, so we probably just need to slightly struggle through, but apologies. I don't think we were expecting to have such glorious weather, but we'll certainly take it. So, Wes, thank you so much. It is brilliant to have you here today. I think the thing that probably will have struck most people in this room, and certainly us at Reform, was, I guess, the mixture of a very kind of clear idea of the sort of staging of what you think needs to be done, but a real pragmatism as well at the heart of it. So just starting off with where we are in terms of the short-term crisis, I mean, we're all very familiar with the pressures that the NHS is facing. We probably all have someone we know, or someone who's told us a story about an experience where they haven't been able to get an appointment, or something's been missed, or a loved one waiting for an ambulance, or there's lots of examples out there. You've talked about various elements of this, but I wonder if you could just give us a flavour of kind of what a Labour government would be doing to relieve some of the short-term pressure that the service is finding itself under.
Yeah, and the things we're doing now in opposition to try and get the government to arrest the crisis as best they can, as best anyone can, given the scale of it. So, I mean, I think it's, and looking around the room, I don't think this is kind of particularly surprising or new context, but we're in no doubt about the scale of the crisis facing the NHS. It's the biggest crisis in its history, and certainly as I've been speaking to former Labour Secretaries of State about what they were doing, and certainly what they inherited in 1997, thinking about the next election and what we would inherit as an incoming Labour government, it's incomparable, and the scale is huge and terrifying. And of course we're all familiar with the numbers in terms of the number of people waiting, the length of waiting times, whether that's for elective care or the waits for an ambulance. But I think we've also seen in recent days and weeks the terrifying personal consequences of the NHS crisis, whether it's the final words of an elderly gentleman lying on his bathroom floor, speaking to the ambulance call handler, the last person he spoke to before he died, waiting 5 hours for an ambulance, whether it was the appalling scene we saw in Cornwall of another pensioner lying under a makeshift tent built by his family, or it's just the everyday conversations we're having with friends and family about the agonising wait they face for treatment, or the frustration and anxiety of trying to get through to a doctor. There isn't a single part of the health service which is performing as well as the public would expect and demand. And I think what makes this crisis different to previous crises we've seen in the NHS over decades is this is probably the first time that people no longer believe that emergency medicine will be there for them when they need it. I think that's what makes this crisis particularly frightening for families. There are things the government can and should be doing. There are some things that the new Secretary of State began to move on. with her statement before the parliamentary recess, but there's much more they can and should be doing, whether that's on doctors' pensions to stop people leaving the health service and to stop people leaving prematurely, but also to get people back in who've left for no other reason they felt forced to retire because of the pension rules and the financial penalty they face, whether it's mobilising the Jabs army of volunteers to help with the vaccine effort this winter, whether we're talking about the flu vaccine or the COVID vaccine or the monkeypox vaccine. There are immediate levers the government can pull, and we'll continue to bash them over the head to get them to do everything they possibly can. But the kind of cautionary note I would add, and this is why I spend much more time thinking about beyond the next election rather than the immediate crisis, because with the best will in the world, we're in opposition, we don't have the power to do things just to try and push the government. We've got to be honest with people about the fact that if, as I expect there will be, a Labour government after the next election, we will not be able to wave a magic Labour wand and improve things overnight. And I think we've got to be honest with the public about the damage that's been done now over 12 years. And if it's taken 12 years to break the National Health Service, it's going to take more than the election of a different government to repair it. And that's why I'm thinking very much in the long term about what we do over a 10-year period, and not just to grip the crisis and to restore the NHS to where it was, but I think to reimagine healthcare and the model of healthcare in this country and make sure we have a National Health Service that's fit for the future. And so at Labour conference, we obviously made big announcements about workforce. I think that is the kind of essential foundation to building an NHS that fits the future, because you don't have a plan for the workforce, you don't have a plan for the NHS, and that's my fundamental criticism of this government. But it's not just about recruiting people to the health service we've known over recent decades. It's about thinking about the future shape of the National Health Service, the future model of healthcare, and making sure that we're gearing that system towards the future and not just trying to re-provide 20th century healthcare, because I think we're not in this space now, but I think if we get to a point where voters believe that they're just going to be asked to pour ever more money into a 20th century model of care, I think they will run out of patience, and the NHS will have run out of time.
Thank you. There's so much to pick on there, and it's brilliant to hear you talking about the fact that we've got to have an honest conversation about what a new model, a new approach needs to look like, that isn't one as inspiring as it was 75 years ago, that was designed for the challenges and the illnesses that we had that long ago. I want to pick up on the workforce point, because you did make several announcements at party conference, particularly notable, I think, and probably music to a lot of people's ears who work in healthcare, was around the doubling of the medical training places. And I just wondered, so, it's interesting with the work we've been doing, when we actually looked at what's happened to the workforce over the last sort of decade or so, we've actually seen a 50% increase in the number of hospital consultants, but we've seen GPs staying pretty much stagnant or slightly going down. We've seen health visitors decrease in that period. We've seen community nurses decrease in that period. So we've got this debate going on that actually the NHS itself is really embracing and pushing, which is we need to get care out of hospitals into homes and into communities, and yet the workforce has gone entirely in the other direction. And so I guess my question is, are you thinking about not just how you increase the number of doctors, but also where those doctors go to really deliver that future model you're talking about?
Yeah, and I think there are sort of three elements to this. One is about retention, because I think, and it's important I make that point first, because I think we announced at our conference what will be one of the biggest expansions of the NHS workforce in history. But I also got a response from the sector today which says, but don't forget about retention. I think that point is very, very well made, because in midwifery, for example, we're losing midwives as fast, if not faster, than we can recruit them. And so we have to take retention seriously, and that's why we've been banging the drum on pensions in the way that we have from opposition. But I also think it's about signalling, and this is why Keir and Rachel agreed that we could make a workforce commitment so soon and so far out, potentially, who knows, from a general election. I want people to know the cavalry is coming, because wherever I've been around the NHS and I've asked the existing workforce, what could I do if I were the Secretary of State for Health that would prevent you from leaving the profession and going somewhere else and doing something else. And one nurse, I think, captured this best, but it was a sentiment I heard everywhere, which was, I just need to know the cavalry's coming. I know how long it takes to train a nurse, I've been through it. I know how long it takes to take a doctor, I work with them. So I'm not expecting it all to change overnight, but unless I can see that improvement, and unless I know that in 10 years' time this experience is going to be better, then I'm off. And so being clear about our ambition for recruitment, I think, is important for retention. But political leadership and the narrative also matters. It's why I thought, we talked a lot about the former Chancellor and Prime Minister and the active harm they've done to the economy. I think we should focus a bit on the Deputy Prime Minister and Secretary of State and the active harm she is doing to the health service. When she was asked recently, I think it was last week, about nurses leaving the profession, her answer was basically, well, if they want to go, that's up to them, but I've got a route open to me to recruit people from overseas. And she may as well just have taken the can of petrol, poured it on the fire, and then said to nurses and doctors going to Australia and other countries, don't let the door hit you on the way out. It is tin-eared and irresponsible and harmful messaging to a workforce that are talking about whether they stay. And you only have to look at the surveys of different parts of the workforce to recognise that many people are thinking of packing up and leaving. And when you look at the government and the leadership and the direction of health policy, you can well understand why. And that's before we get on to her other positions on things like smoking cessation. So that leadership is important. So in terms of what we've announced in practical terms, so you're right, doubling the number of medical places, increasing the number of nursing and midwifery training places by 10,000 every year, doubling the number of district nurses qualifying, and increasing the number of health visitors by 5,000. And that's on top of the pledge we made last year on mental health and recruiting an additional 8,500 specialist mental health workers. Fully costed, fully funded, and significant that we've made that commitment this far out. That in itself is important, would make a big difference, but I think it's partly my job to signal to those people that are coming into those training places and thinking about their future career, to signal to them what we think will be important and where we think the exciting challenge for medicine will be in 5, 10, 15, 20 years' time. Because if we get this right, and if we get the modernisation right, for me, the future of healthcare in this country is not about acute hospitals and just treating more and more people in district hospitals. It's not even simply about faster diagnosis and treatment. It's about prediction and prevention. It's about making sure this country is at the cutting edge of life sciences and technology, and to make sure we're harnessing that technology in a smart, thoughtful and personalised way that we can prevent people from becoming ill in the first place. It's about making sure that there is more care in the community. It's about making sure that we not only fix the front door to the NHS in primary care, but we reimagine it so that it is an attractive place to work, but also a really attractive place to be a patient. And we're a million miles away from that now. I guess the question for me, and this is, I hope, a two-way conversation, lots of the things that you will have seen me say in my conference speech about the kind of change and modernisation I want to see, you will probably find reflected in some way or another with varying degrees of prominence in every NHS 5-year forward plan. And so what I spend a lot of my time doing now, with one of the few advantages of opposition, which is time and thinking space, going around and asking the question why. Well, why isn't this happening? Why isn't this given the priority it should be afforded? Why is the NHS so short-termist and driven from crisis to crisis? And what do we need to do, either in terms of public policy, in terms of priorities, in terms of funding and resources, in terms of governance, in terms of systems, to make sure that in 10 years' time there isn't another Shadow Secretary of State sat here saying exactly the same thing and cursing his or her predecessor, which I hope will be me. I really hope people aren't cursing me in the future, saying you had that great opportunity, you had that great plan or vision, why didn't they deliver it? And so I think the why is, an understanding why we haven't done these things is a really important step to understanding how we avoid repeating those mistakes in the future.
And you're absolutely right, and one of the things we've been reflecting on is just, I mean, we were reading a white paper, I think it was, that Patricia Hewitt published, you know, what would that be, sort of a couple of decades ago, exactly making that argument that we need to see a shift. We want to see the amount of money going to hospitals declining, we want to see the amount of money going into the other areas increasing, and you know, the long-term plan states exactly that and commits to it, and yet we've seen an increase in the proportion going to hospitals for the last 5 years as an amount of the total healthcare spend. What do you think the levers are, and how far do you think that's going to require quite an honest conversation with the public? Because, you know, the public understand you're going to get another hospital, you know, you're going to get a new wing of a hospital, you know, the kind of shiny new things. It's harder to have the conversation that says, but if we invest a bit more in this public health area, then we might get longer term better outcomes, which then reduces demand down the line. So I suppose, are there particular levers you're thinking about in terms of shifting, making that shift that successive Secretary of State's heads of the NHS have called for, and how hard is that challenge, the conversation with the public, going to be?
Well, I think the public understand that the NHS isn't working and that it needs to change. And the kind of the political argument I'm prosecuting at the moment is to say to those people who say, you know, an NHS publicly funded free at the point of use, which we could afford in the 20th century, is now no longer affordable in the 21st, and that's why this is all broken. You know, my argument is a very different one, which is it's not the model of funding that's broken, it's the model of care. And I think the public well understand that we need to change the way that we deliver medicine in this country and the way we think about our healthcare. I don't think they need much persuading on that, and I think if I went into an election simply saying more money and more staff for the NHS, I mean, you know, the public don't tend to need convincing that they can trust the Labour Party with the NHS. It's even in the Corbyn years, I think we still had a narrow lead on the NHS, and if it could survive that, you know, Labour's poll lead on the NHS could survive anything. It is more about, I think, building public confidence that we have a genuine plan that can work, and also showing the public more generally that the Labour Party is now full of serious people who have a plan to tackle the big challenges facing our country. And I guess the challenge for me, and the thing I spend most time thinking about, is how do we make sure that we align the urgent crisis and our response to that with also taking the right long-term decisions. Because, and I don't mean this as a big criticism of NHS England really, but I think for fairly obvious reasons that NHS England looks and feels and sounds like an organisation that is very much focused on the immediate crisis and is losing sight of the long term. And even when I think about the board of NHS England, which if anything should be the part of the organisation that challenges its thing longer term, even I think the board of NHS England is being sucked into the here and now and the urgency of the crisis. So I think the way in which I'm trying to use this time building up to a general election is to make sure that in terms of that 10-year forward plan that I want to agree with the NHS and in partnership with the system, I want to have a good draft ready ahead of the election to give to NHS England, to give to the department ahead of the general election, so that on day one, we've got something that we can run with and work with, and we're not wasting time, because the NHS can't afford, kind of a long induction period from yet another Secretary of State. And I appreciate I'm not doing quite as well as Rachel Reeves yet. She's on her 4th Chancellor, I'm only on my 3rd Health Secretary. But it's really not, this churn for the system is really not good. And when I think about kind of what I've seen, Sajid Javid, when he came in, commissioned a vast number of reviews on some quite big issues. And, I know he's taken some criticism for that, but I would say at least he was asking some of the right questions. Steve Barclay came in very much understanding he was a caretaker, and as far as I could tell, spent the summer phoning troubled trust chief execs once a week to ask what they were doing about things that were beyond their control, like primary care and social care, to deal with the queues at the front door and delayed discharge at the back door, which I didn't think was a particularly helpful or constructive intervention. And then Therese Coffey's come in and basically stop phoning troubled trust chief execs, in fact stop phoning anyone, she's hardly in the department. She's too busy phoning Tory MPs and trying to manage the bin fire of the Liz Truss premiership. And worse still, she took all of those Sajid Javid thoughtful reviews and pieces of research he commissioned, just junked them. So that's now effectively 3 Secretaries of State worth of inactivity in a system that is in crisis, and that, you know, that really worries me actually, and I'm worried about this period between now and the general election. I think we probably will run the course and run for another 2 years, and I really worry about the disintegration that will continue in that period when time is of the essence and patients are running out of time, and patients, I think the government has already run out of time and run out of ideas, and that's not a good place for a health system in crisis to be.
And but there's a few things there which are, I think, you know, tremendously important points. So that first one about having a Secretary of State for health and social care that really doesn't have any of the levers around social care. So, you know, calling and saying, you know, what are you doing about freeing up the space, and Trust saying, well, we don't have control over that. One of, I suppose, you know, one of the both opportunities but perhaps criticisms of the ICS model, which is supposed to integrate those things, is actually that the resource, the power, the control is still sitting at the hospital end. You know, we just had out, was it this week or last week, 2/3 of ICSs are already, I think it was 2/3, I'm sure someone will correct me if I'm wrong, but I think 2/3 of ICSs are already in debt now.
Right.
It's hard to see how, if you've got the trust end being in debt, that actually all of the money isn't going to still be going to the hospital when social care is so desperately in need of more investment.
Yeah, so, and actually let's sort of turn that on its head a bit and think about examples of good practice. So when Rachel Reeves and I were at Leeds General Infirmary, they were talking about the way in which their trust had taken the decision to use some of their acute budget and spend it in social care to deal with delayed discharges. And that was better value for money for the taxpayer, better experience for those poor patients who are well enough to leave hospital and are stuck there, which is certainly not the best place to be for their recovery. And of course it's better for all those other patients that are waiting for beds that could be freed up. And so my question therefore to the rest of the system is, well, why is it that in some places trusts or trust boards or you know, ICSs are taking those sorts of strategic decisions, but others aren't? And is that a challenge around governance and risk aversion on the part of directors, and sort of anxious about spending money on activity for which they're not directly accountable? What's going on there, and how do we make sure that what I consider to be excellent practice, and that it's putting the patient first fundamentally, and taking taxpayers' money and using it wisely and improving the flow of patients, why is that not happening everywhere? So I think a test for me, because I'm thinking about integrated care systems from the point of view of evolution rather than counter-evolution. I don't really have a burning desire to come in and on day one say, I know what this system needs, a top-down reorganisation that I can put my name on as my brand legacy. That's the opposite of where I want to be. If people do think structures aren't working and governance needs to change, I'm open to evidence-based and informed suggestions, but I am not coming in instinctively wanting to upend the whole system and spend lots of time on structures. I think we need to think about how the system as a whole works, the model of healthcare, and patient experience. And I get the other thing I'd say, just on a related point about good practice. When you think about those queues of ambulances out the front of hospitals, and what we do about that, the best trusts are those where the chief exec and directors are basically saying, from the moment the ambulance pulls up, these patients are our responsibility. We will take ownership of them and we will manage the risk. The worst examples are those trusts that say, well, so long as they're on the back of the ambulance, they're not our problem, they're not our risk. So we'll kind of manage our kind of crisis in the hospital, and we'll get them in when we can. And I think that latter attitude is not one that's putting the patient's interests first, and not just thinking about the patient at the back of the ambulance, but thinking about the pensioner who's lying on the bathroom floor who needs that ambulance urgently. And so again, those are areas where I'm looking at what I consider to be the right judgment, the right leadership, the right decisions in some trusts and some hospitals. I'm wondering why that's not the standard elsewhere.
And just on that, thinking about again the sort of the longer term vision that you're laying out around a system that's much more about caring for a patient, you know, in the most appropriate place, because let's face it, most people don't want to go to hospital. In fact, it's probably more dangerous for them to go to, you know, I know you've talked about things like kind of virtual hospitals, and, you know, I think in Israel they call it home hospitalisation, and, you know, so it's kind of, you've got this model, but there's clearly a tension between saying to an ICS or a, you know, kind of regional area, you know your population best, you know, we need to devolve decision making, money, kind of, etc., to your area to be able to decide how to invest to the, you know, to serve your population most effectively, versus a very interventionist Secretary of State who does want to dictate this is the way, you know, people should do things. Where do you see yourself on that spectrum?
Striking the right balance.
Exactly. How would you do that?
It's a really good question, actually. I mean, I'm instinctively a devolver. You know, I kind of think where you want to be is national standards, national expectations, so you provide consistency of outcomes and quality. In this case, we're thinking about quality of patient care, but I think it applies equally to other public services. But you know, you recognise that what will apply in my local trust in outer North East London, or indeed to the health system in London, is going to be vastly different to what you might see down in Cornwall or up in Cumbria or you know, across East Anglia. So you know, that's why I think there's a lot of potential actually in those integrated care systems to take the right approach. And also, I mean, one of the things I'm thinking carefully about is you know, as Secretary of State, the levers available to me will be very different to the ones that were available to my Labour predecessors. And even if I wanted to reinvent some of those levers, that will take time and no doubt political pain as well, and it will be hugely disruptive. So I need to think about how I exert influence in the system and bring that influence to bear in a constructive and helpful way that delivers better outcomes for patients and a more cohesive, integrated system. So it's one of the issues that I'm thinking through carefully and talking to people as I'm kind of going around about, you know, what they need from the Secretary of State, what they need from the Department of Health and Social Care, what they need from NHS England, and of course the relationship between the department and NHS England as well.
It's a beautiful segue for the last question I'll ask, and then I'll open it up, because I'm sure there's lots of people who would like to ask particular questions about all the different areas we've touched on. But you mentioned there your Labour predecessors and kind of what they were able to do, and if you look at what they, you know, Tony Blair and his health secretary did around wait times and kind of wait lists and that kind of stuff, and really, really impressive stuff. But one of the other differences was the financial situation that they came into. So, you know, particularly in that early stage when they really made an impact, sort of up to 2005, the rate of increase of the NHS budget was 3 times GDP growth. We're in a very different world now. That's going to be a huge challenge, you know, even come 2 years' time, if that is how long we wait. I was really struck by something that I think you said in a Telegraph interview, where you said that, you know, there's no way around the fact that in the short term, to fix things, we have to have more investment. There's also no way around, in terms of a long-term fix, the fact that we have to recognise that there isn't going to be huge year-on-year investment because it's not sustainable. And I just wonder if you could say a little bit about that slightly daunting, I would have thought, challenge of going in and knowing the finances are not in a great position, let's put it that way, slightly euphemistically, she says.
Well, I think Amanda Pritchard was slightly less.
Well, exactly. I was thinking about quoting her, but I won't. But, you know, what does that? I mean, because the reason
family
could
audience,
be.
we don't want to use that sort of language here.
Exactly.
And look, and to be honest, I'm glad that NHS England, albeit I'm not sure Amanda would have liked to have been quoted in quite that way so publicly, but you know, I do think the NHS and its leadership have actually responsibility to the public, to Parliament, to patients, to the staff that work in the system. They do have a responsibility to be honest about the kind of financial challenges they're facing and the kinds of choices that then creates. Because I think, you know, most people in this country, when they sort of pick up a newspaper and see that the NHS is warning of potential cutbacks in areas like cancer care, they kind of go, oh, hang on a minute, we know that cancer if there's one thing that the NHS has tried desperately hard to prioritise, even throughout the huge disruption of COVID, and I speak with personal first-hand experience of this, it's cancer care. And so what kind of universe are we in where there are real threats in that particular space? It kind of speaks to just how grave the crisis is. So I think people should see our commitment on workforce as a significant down payment in terms of Labour's commitment. Rachel Reeves, quite rightly, is being very, very sort of prudent and cautious with spending commitments this side of an election. It's interesting, isn't it, that until the last couple of months, Labour's taken a lot of flack actually for being too cautious in opposition, not making enough policies and not making enough commitments. And I think that judgment call has been proven absolutely right when you look at the contrast between where we are as an opposition and where the government is, and the risk of over-promising and under-delivering. So it will be difficult, and dealing with Rachel will be difficult. Dealing with Pat McFadden in government will be difficult. But fundamentally, Keir, Rachel, Pat, they do understand the scale of the NHS crisis. They do understand the reform and modernisation that's needed, and I think they understand that in order to get to where we want to be, which is an NHS on a financially stable and sound, secure footing, there's going to be a big short-term challenge, and so I think that the fact we've had that big commitment on workforce so early on says something not just about sort of where I am in terms of my priorities, but also where Keir and Rachel are in terms of theirs.
Brilliant, thank you. I'm going to open it up to questions. See, already I've got hands shooting up everywhere. If I take three, and then if that's fine with Wes, we'll answer those and then answer. So front row here, the lady there, and then the gentleman just on the end here. I think your hands were the quickest up. We don't have microphones, so just go ahead. Yeah. If I can ask you if you can introduce yourself, just name and organisation so that we've got context.
Hi Wes, Sean Walsh from Cancer Research UK. I was just a couple of reflections. Really pleased about the workforce commitments. We and everyone in the sector, I think, has been crying out about workforce, and highlighting the importance of retention is absolutely critical. But my question is really relates to something you both talked about in relation to public health and prevention. It strikes us that your public health funding has suffered considerably over the last 12 years. We're also in a situation where weight of demand on GP services and the NHS is increasing, and what we're struggling to understand is why we can't take a more enlightened position on the prevention agenda. And what I mean by that is, if we can reduce the burden and demand on the health service by stopping people getting ill so soon as they do right now, that would save a huge amount of money, energy and investment. And by way of example, we've flagged this before, but smoking is still responsible for 150 cancer cases a day. Those are preventable cancer cases. They cost people who smoke £2,000 a year. In a cost of living crisis, that £2,000 is critical. It costs the society and the NHS.
I'm conscious there's a lot of people who want to ask questions.
I'll wrap up. So yeah. I guess what we'd really want to see is the opportunity to put prevention up front in a new rebuilding or reimagining of the health system, because it too often is forgotten, and yet it would save us significant sums and improve the well-being of the nation.
And I think obesity and diabetes goes into that category as well.
Absolutely.
If you think about the costs they've got. Just the lady here, you can just tell us who you are.
That was really interesting. I'm Rachel from the Patients Association. You talked about the honest conversation and a partnership with the system. I'd love to hear about how you're going to intend partnering with patients, because I think as we look to the future of health and care, it has to be done in partnership in the design and delivery of all the services.
Perfect. Thank you so much. And just the gentleman here.
Yeah, hi, I'm Martin Marshall, Chair of the Royal College of GPs and a GP in East London, and Chair of the Nuffield Trust as well. I was interested in your response to the challenge of how we shift resources from the acute sector into primary community and services and into social care as well, because as you've described, many people try to do this and always find it really difficult. And the practical challenge here is, how do you say to the public, we're going to spend less money in the last 3 or 6 months of your life and more money in the first 5 years of your life. We're going to spend less money on this individual and more money on reducing inequalities in communities like I work in and you live in. And you said you thought the public got that. I don't think they do at all. I think it's a massive challenge to get the public to shift their opinion, to do the right thing in terms of where the resources need to go. So I'm interested in pushing a little bit harder on that.
How do we do that? Yeah, perfect. Over to you, Wes.
Yeah, let me take them in reverse order. It's nice to see you in person rather than on Zoom, Martin. I think it's about taking a kind of a phased approach over time. You know, very early on in this job, I was sort of sat with someone who was saying, well, the problem is we're spending a huge amount of money on life-extending treatment for old people with cancer who are going to die anyway, and we should stop doing that and start doing something else. And I sort of nodded along and said, oh, absolutely agree, that sounds fine, except you've just killed my grandmother. And which goes to the heart of the challenge. And, you know, I would argue that when was she first diagnosed with terminal cancer? So back 2013, 2014, I think I went to see her for the last time, and she's still going. And I'd say that those years we've had since have not been wasted at all. And I think we've got to be careful about not kind of painting a miserabilist picture of the future, where we say, well, the problem is, you know, you old people are costing loads of money, we've got to let you die because we've got to think about the kids in the future. I think we do have to take a phased approach over time. In terms of how we shift resources around the system, and I'm keen to work with people to work out how we get there. And I do think primary care has a really big role to play. And I'm really keen to work with your Royal College in particular, because I think that, you know, one of the things that, for all of the narrative about primary care and GPs in parts of the media, as I've been going around, I've been finding lots of GPs who actually really want to see change in the way the system works. And want to help and want to be part of that conversation. So I'm very, very happy and keen to work with you on that. Rachel, on patients, the speech I gave at Labour conference was very heavy on patient choice and patient power. And it's something I feel very strongly about still as a patient in the system, where I see regularly examples where the patient is not at the centre of thinking, even though the overwhelming majority of people who work in the National Health Service care fundamentally about patients. That's why they're there, and they're not doing something else. And goodness knows we've given them lots of reasons to pack up and go and do something else in recent years. So I'm really keen to work with you and other patient organisations to think about, because I think there's a number of things. One is about the ways in which we give patients a stronger voice in governance. But actually it's I think even more about how we give patients greater choice and flexibility in terms of the way they want to receive care. There's been so much about GP appointments, for example, and face-to-face and the lack of it, and people struggling to get through, and I've got lots of sympathy on both those fronts, particularly the 8 AM phone calls that I'm determined to put an end to. I kind of screamed when I heard Therese Coffee Station going to introduce a new telephone system, as if it was a revolutionary piece of technology that was going to change the way people engage with primary care. I think what people are missing is that, yes, there are lots of people who do not feel they have enough quality face-to-face time with GPs, including, by the way, GPs who want more face-to-face time with their patients and that continuity of care. But we're also missing the fact there are people like me that are dragged into GP surgeries or dragged into a hospital for a follow-up meeting with with the consultant. I don't want to be there. I'm happy to do it over the phone. I'd like to do it on video if necessary. I'm very happy to run through kind of diagnostic tools online. Of course, that won't be appropriate for everyone, but that's why choice and personalisation is a great thing, because in having faster, easier, more convenient tools for me, we free up critical staff time for other people who will require, and evidence says, continuity of care delivers better outcomes. So I'm very keen to work with you on that. I've said very clearly I want to be the shop steward for patients, and I take that very seriously, and I do lots of mystery shopping on the NHS myself, which is enlightening. I pray for my poor trust locally to get my mystery shopping feedback. And finally, Sean, on public health and prevention, I'm curious as to whether the government is still committed to smoke-free 2030, because there is no sign of any activity to get us there, and all things being equal, we are not going to achieve that 2030 ambition. So I think the question for Therese Coffey is, do you agree with it? If so, what are you going to do to achieve it? Or have you jumped it, in which case I think you owe the public an explanation, because the concern I have with our newish Secretary of State is not so much that the tobacco industry has her in a vice-like grip, is that she is the tobacco industry and has public health policy in a vice-like grip. It really concerns me, just as we've seen the dangers of an ideologically blinkered view and the damage it can inflict on the economy. I think we have a dangerously blinkered ideological view of public health, and it's running the Department of Health, and I think that should concern us, as much about the health of the nation as the health of the economy. Because if there's one thing our current experience as a country is showing us, is that the health of the nation and the health of the economy are inextricably linked. And it goes back to your point about where we'll be on Treasury and money. The Bank of England Monetary Policy Committee very clearly showed that having more than 300,000 people economically inactive because they're ill is bad for the economy, and a big part of that is NHS waiting lists. Look at the impact of mental ill health, particularly younger people in their 20s, and what that does to labour market participation. We've got to start seeing health policy also as economic policy, and think in those terms. And unless we're ambitious on public health and healthy eating, smoking cessation, reducing risky and harmful behaviours on things like drugs and alcohol, we're not going to get to where we want to be. And that's my, from the point of view of the scarcity of resources and the fiscal tightening we're seeing, I think it is even more outrageous that we are spending and wasting so much money in healthcare in this country because we're spending money on the price of failure. And that's the big opportunity and the big prize, I think, for the longer term. If we get the strategy right and we get the focus up front right, we will end up not only delivering better patient outcomes, we will save a huge amount of money and contribute to economic growth, which means that we don't have to raise people's taxes all the time.
Can I do a quick follow-up, and then I'm going to open it up, but just because I think that's such an important point, that the other thing I think people are increasingly talking about is the fact that health equals wealth, not healthcare equals wealth.
Yeah.
And actually, I suppose it's a slightly provocative or challenging question, but as Secretary of State for health and social care, would you be willing to say, in any scenario, do you know what, actually spending more on that other public service will have a bigger bang for my health buck than another £1 spent on hospitals?
Well, that's a good question. That's a really good question. Am I going to give some of my NHS budget away?
This is the challenge across government.
It's a good argument, actually. Keir's already talked about the importance of health in every policy, and that's the approach we kind of want to take cross government. So I think there is a case to say, a particular intervention on something like housing or social security is actually really good for health. I mean, by all means, let's expand the size of the mental health workforce and improve that community access and improve support in schools. But that's going to be a huge amount of money that doesn't touch the sides if we are fueling a mental health crisis because people are living in substandard accommodation, or their benefits are being cut in real terms and they're struggling to afford food for their families, and kids are going to school worrying about the row they heard with their parents the night before because they couldn't, they're not able to turn the heating on. So I think we have got to see health in the round, but we've got to be careful though. I mean, the one cautionary note, I remember Gordon Brown, who I have lots of respect for, was almost making the case for being able to prescribe things like heating on the NHS, and I think we've got to be so careful at a time where the state has been degraded and run down to the extent that it has. I think the worst thing we could do is to try and make the NHS the state. We have got to try and rebuild public services and rebuild the good society. That would be good for health, but I think we've got to be a bit careful about not expanding the realms of the NHS to pick up the pieces for a failing state. We can have a whole conversation about social prescribing, but I shall instead go to the hundreds of hands. Loads of questions. Exactly. And I'll try and be more succinct so we get through here, and then if we go over there, and then I'm going to go to the very back. So three, if I can ask you, because I mean almost every person has their hand up, so if I can ask you to be really quick and very much keep it to a question, that would be great.
It's Alex Fox. I sit on the NHS Assembly, which advises the NHS England Board and does give it some of that breadth and length of view that you're worried it doesn't have. But my job is working for the Mayday Trust, which is developing more radical approaches within long-term support, particularly based on helping people build their own strength and resilience in place of some of our traditional models. And I just wanted to kind of push you a bit on radicalism, and particularly in relation to long-term support and social care. We've been very health and medically focused in this discussion. Health secretaries tend to get social care, but usually the day after they leave that role. Do you get social care is the key to everything, and how radical are you willing to go on it?
Great, thank you. Forgive me, I can't remember who I said now. Was next? Yes, sorry.
Yeah, thanks. Hi, Wes. I'm Andrew Catter. I'm the Chief Executive of Integrated Care 24. We're a social enterprise. So my question for you is where social enterprises and CIC fit into your provider landscape. As you know, we're major providers of both primary care and community care services, yet at times it's not a level playing field with the statutory NHS, particularly around the delivery of social value. So I'd be interested to hear what yours and Labour policy is on strengthening the contribution that social enterprise can make to the NHS and social care.
Brilliant, thanks so much. And at the very back.
Hi,
Sorry, no, one back, and then I will come to you next. Yeah.
Sorry. Hi, Caroline Abrahams from Age UK. I wondered if you'd say a bit more about your vision for the community and for carers spanning social care, primary care, community health services, hugely important for older people in our country, and also perhaps a little bit about the role of the voluntary sector, because we're huge supporters of the NHS, of everything they do, but actually one trick they haven't quite got right yet is getting the most out of the voluntary sector.
Yeah.
And I wonder if you have any thoughts about that.
Great. So kind of similar questions, I suppose, slightly voluntary sector and social enterprise, and then how radical on the kind of social care agenda.
So I'll kind of
and do you get social care, I think was the precise
Yeah,
question.
yeah, I hope so. Because if I don't, we are in big trouble. I'll come back to social care last. Just on, firstly, on those two related questions from Andrew and Caroline in terms of the voluntary sector. I come from the voluntary sector. I think in this space, there's been a huge amount of innovation and creativity, and necessarily because of the challenges facing the voluntary sector in terms of the economic climate, and a huge amount of cost-effective innovation as well. I'm very comfortable with the voluntary sector being part of public service delivery. I'm highly suspicious and cynical, and in some cases highly critical of the private sector and the profit motive, and the way in which, particularly if you look at social care, and some of the worst elements of venture capitalism, which I think even Jeremy Hunt described as the worst face of British capitalism. So interested what he thinks as Chancellor. I think private equity owned, not so much venture capitalism, sorry, private equity owned care homes. I think we've got a big problem with wealth extraction from a sector that doesn't have enough money. And when I talk to providers in social care, whether private sector or voluntary sector or publicly owned and provided, the consistent theme I get is we're trying to run good quality care on a shoestring. So I wonder how it is that one part of the sector is able to extract vast amounts of wealth from a system that is so clearly underfunded. So that's a long way of saying I think the voluntary sector is really important, and the not-for-profit sector is really important. Kind of not an ideologue about who provides public services. What I care about is good value and good experience for patients or public service users more broadly, and I care about good value for money for the taxpayer. And then, particularly in terms of older people, I think one of the advantages of having John Ashworth doing his new role at DWP, he's thinking about, I think, older people quite strategically and across the board, and bringing his long-standing shadow health and social care experience to bear there, and we work closely together. I think we've got to have a kind of wider vision for ageing, because the kind of the fundamental societal challenge is that we're living longer, but we're not having quality of life for longer, and that's a big problem. And I don't want us to kind of paint a picture of the future which is, sat in our chairs looking back on a life well lived. I think people want to live life to the full until the very end, and we should equip them to do that. And that's a much wider, bigger, I think, cross-government agenda, but one where I think care in particular has a role to play in terms of supporting people's independent living and choices, and having a sense of agency and control over their lives right through to end of life, as we would expect at any other stage of our life. So I'm very keen to pick up that conversation with you and work with you on it. And then that leads neatly into Alex's sort of fundamental challenge of how radical can we be, and do we recognise social care as everything? I think a cautionary note and then the blunt answer, yes. I think the cautionary note is, don't be surprised if I don't spend a huge amount of time in the run-up to the general election campaigning on social care. There is a reason why social care has been consistently overlooked and deprioritised by governments, and it's because it's not well understood by the public, unfortunately, until it's too late and people encounter it and either realise that it doesn't meet their needs, or it's very, very expensive for themselves or for someone that they love. And for that reason, a lack of understanding about social care, it's not going to be something that we win or lose an election on, so we're not going to perhaps give it the airtime it deserves. But that doesn't mean it doesn't preoccupy a huge amount of our thinking time and planning time. I asked the Fabian Society, I'm sorry if I'm allowed to mention the Fabian Society at a reform event, but I asked
there are other think tanks, it's not good.
Yeah. I asked the Fabian Society to do a piece of work about what a future national care service would look like, and the steps we would need to take to get there. So we have the beginnings of a plan. That won't be the end of the conversation. I'm very passionate about co-production. I want to make sure that the voices of people who use social care are heavily involved in thinking about what it is we're providing and how it is we're paying for it, and not just older people, which we mentioned, but working age disabled people who make a huge proportion of both the budget and the users of social care, and who rightly demand greater independence and freedom and quality of life for themselves too throughout their lives. So yes, it's something that preoccupies my mind a lot. So don't worry if you don't see it as one of our 5 pledges. It will be there in our manifesto, and it will certainly be at the heart of an agenda for a Labour government. Because I think the one thing that the current crisis does give us, I think, is a route into the voters as to how important social care is. Because I think from some of the voter research I've seen, voters do understand the relationship between social care and delayed discharges. And I know that people actively engaged in social care say, no, it's not all about the NHS, social care is important in and of itself. And of course that's right, but if that's helping people to understand that social care is important, let's grasp that opportunity and let's make sure we do something about it. And better pay, terms and conditions for social care workers is going to be really important. In fact, I think I always refer to them as care professionals. We've got to build that professional workforce, but we've also got to, I think, rethink what's provided, and then crucially how we pay for it, and those are quite difficult and thorny questions.
Great, thank you. I'm going to take a handful more. So the gentleman who I didn't come to last time, it's a lady just in the middle here, and then the lady here who's had her hand up. So if we start at the nearly back, there we go.
Hi, my name is Jahangir. I'm an emergency medicine doctor in East London. I'm a Tower Hamlets boy, just like you. I was interested to hear about your workforce plans. As someone who's already in the system, as someone who's come here straight from a night shift, I'm really interested about the retention side of your workforce plan. You mentioned pension reforms for my consultant colleagues. My junior doctors and nurses are balloting for strike. This morning the GMC published a paper on workforce, noting that if nothing changes, we'll lose 16,000 doctors by 2030. Last month we had about 40,000 nurses leaving the NHS in 2021. I've got band 3, band 4 colleagues who are porters and healthcare assistants who are working full time and accessing food banks. My question to you is, do you think the Doctors and Dentists Remuneration Body and the Agenda for Change contract is fit for purpose?
Good question.
Thank you. And the lady who's just there.
Esma Kyson from Astor Along UK. So my question is about whether you're going to have a renewed focus on tackling health inequalities, and whether kind of scarce resources will be focused on protecting the most deprived in society, such as people with lung disease.
Great. Thank you so much. And then just the lady here in the middle.
Rachel from Alzheimer's Society. You mentioned about the work of previous Secretaries of State. Sajid Javid announced a 10-year plan for dementia in May. We're now hearing that Therese Coffey is going through these condition-specific plans and scrapping them essentially.
Yeah.
And I wanted to know if Labour would have a similar approach, a dementia-specific plan for the 900,000 and rising people in the UK that are living with the condition.
Yeah.
Thank you so much.
Yeah, these are great questions. I'll take them in reverse order. Rachel, your question, it kind of comes back to what I was saying about Therese Coffey going around scrapping loads of stuff that's been agreed. It really worries me, partly because I've tried really hard in this role so far not to get dragged down the route of just focusing on individual conditions, although recognising that you do need a specific plan on things like dementia, you do need a specific plan on things like cancer. I've started with trying to fix the fundamentals first, but it really does concern me. I thought we'd had some political consensus on dementia, and you'll have noticed John Ashworth made a very similar commitment on investment in research to the government when he was my predecessor. So we will hold their feet to the fire on this, and we are just talking about this earlier today in my office actually about picking up that issue in particular, but more broadly as well. So I will come back. Let's meet separately and talk about what we can do and what we can commit to. But I think what I would like to do right now, and from an opposition point of view, is to try and stop the rot and stop things getting worse. It sort of feels like, having demolished all of our achievements, the Conservatives have now started on their own, which seems like a very silly thing to do. And Esther, on a related point, why would they scrap the Health Inequalities White Paper? We haven't even seen it, and seen it in action. But I kind of think this is what Labour governments do. It's part of our kind of core DNA. And so it will be a priority for me, tackling health inequalities, and it ties to the point I made right at the outset about the importance of data, genomics, science and technology. Enormous potential there for not just better personalisation, but better allocation of resources and focusing right down on the inequalities that exist in different parts of the country. So I'm absolutely committed to resurrecting that focus. And Jahangir, your question at the top. I can't pretend things are going to be easy, and I wish I could say on day one of a Labour government we'll deliver pay restoration. Pre-97, we made a broad commitment to pay restoration. Didn't put any deadlines and timetables on it because we were honest and said, we're going to have to get there as economic circumstances allow, but we did do it and we did achieve it. And I think that says something about how Labour approaches these sorts of issues. And similarly, when we've been in previous rounds of heat around pay, I've emphasised again and again my concern about people on the lower bands, on the lower pay scales, who are really struggling. And I say this with great respect, not least because I know we have got retention crisis with people who are far better paid, but I don't believe that some of our well-paid consultants lie awake at night worried about their own salaries, and I don't think they want or expect me to lie awake at night thinking about their salaries. I think they do lie awake at night wondering whether or not they're going to turn up to a fully staffed shift the next day, and I hear from them a concern about their colleagues and the people you mentioned, and I think we have got to we've got to look seriously at this as part of a wider workforce plan. And also I think beyond sort of the headline pay terms and conditions, I am interested in things like making sure people have access to hot meals overnight, making sure that people aren't hit with additional charges on things like parking. There is a cost involved in those things, and I don't want to make promises I can't keep, but I do want the workforce to know that I am alive to this and concerned about it. And I'm not going to be on the picket lines if and when people go on strike, but I will be doing the thing that they expect me to do, which is to make sure they have a better government and a better approach. I hope that the government sees sense and recognises that when you've got, Royal College of Nursing balloting for strike action and for the first time in its more than 100 years of existence, things really are at a dangerous tipping point. And this is not about government versus unions or some of the sort of the tired old political battles. It's actually about how do we keep people in a profession that's already dangerously understaffed.
I'm going to take two more as final, but they really must be very, very brief because we are almost at time, and I'm sure Wes has other things to get to. So just two final. So in the very corner at the back. Sorry, yes, yeah, and then just at the front here.
Hi, Charlotte.
But if you can be very, very quick. Thank you.
My question is on a very specific public health measure, which is the tobacco levy, which would cap the profits of tobacco companies in the UK at 10%, which would raise £700 million as proposed by Action on Smoking and Health. Will the Shadow Secretary of State consider this measure?
Well, that's a very specific question. That's perfect. Thank you so much. And at the front here.
Got a lot to live up to. Sorry, Emma from the Red Cross. People who frequently attend A&E make up less than 1% of the population, but something like 29% of ambulance journeys.
Yeah.
It touched on a lot of the points that we've mentioned, so the health inequalities, looking at the workforce, because it's a lot of non-clinical staff, and also the emergency crisis right now. Is this going to be a group that you'll be focusing on?
Oh, these are nice, short, sharp questions to finish with.
Perfect, thank you.
Yes, in answer to your question, Emma, that's a nice, easy one to answer. And I'm so glad you asked the question, will I consider, rather than will I commit? Yes, I will consider it. This is not solely my area of responsibility, and fiscal policy is a matter for the Shadow Chancellor, and I'm definitely not going to make commitments on her behalf without asking her, because I will be the former Shadow Secretary of State for Health and Social Care.
A true politician's answer to anything.
But you know, I think Javed Khan set out a very ambitious and achievable plan for smoke-free 2030, and instead of junking it, Therese Coffey should read it.
Wes, thank you, Shadow Secretary of State for Health and Social Care. You have been absolutely brilliant. Thank you so much for giving your time up today.
That's been
to come
great.
and talk to us. Thank you, everyone. I know it's very warm in here, but you've been outstanding. Great questions, nice and short, not lots of commentary. I love you all for doing that. Thank you so much. And we are going to have tea, coffee, biscuits, etc. outside. Now, if you want to hang around, chat, network, etc., please do. But otherwise, can we please thank Wes in the UK?